Good afternoon, everyone. And look, it's so unfortunate. I'm so sad not to be with you here in person. Tiff, Beck, and the whole team in South Australia and the International Learning Collaborative were so looking forward to seeing all our friends in Europe and across the world. We can't believe it's 2 years since we've seen each other, and our thoughts and our hearts and our very strong energies are all with you. So I know that there's myself and Mette are the last two keynote speakers of these last 2 wonderful days conferences. I know, having looked at the outline, you have had wonderful inspirational speakers, and so Mette and my great privilege is to close things off. So what I'm going to talk about today is why fundamental care matters to you. Now, when you think about titles, then you start to think, oh, maybe I didn't get that right. Because maybe I should have framed it as why fundamental care ought to matter to you, or should matter to you, or how it all matters to us. So there's lots of different ways. Now, good news is I'm not wearing the same earrings, or not the same colors. I checked that out this morning. My name, for those of you who don't know me, is Alison Kitson. I'm the Vice President and Executive Dean of the College of Nursing and Health Sciences. Look, I could even sort of stand in front of it like a hologram. Also, co-founder of the International Learning Collaborative, and have a number of associate and adjunct professorships that keeps me connected to the people who share passion for how we can improve care. I'm speaking on behalf of a number of researchers and research teams from the Caring Futures Institute, and this is an institute that was set up a couple of years ago with the sole purpose of studying self-care, how we care for ourselves and how we can care for each other people, either in professional roles or in informal roles, that will help us really put caring on the map. And of course, there's no good doing the research if you don't know how to make a change. So that's why we embed everything in our knowledge translation sort of envelope. So what I want to do, a bit like the weather girl, able to sort of show you what's happening. Going to start off with, well, why is looking at fundamental care a problem? What's the problem? Go into a bit of background about what we know about care, looking at some of the work that we've spent this last decade or so doing, trying to create a framework that is intuitively but also empirically coherent. Share a bit with how we're refining and testing the framework, and then go on with next steps. Now, I propose to rattle through this in the next 30 minutes or so, so that Mette will be able to slide in gracefully to the end of the allotted time. So what is the problem that we're trying to solve? Well, from the very moment that we enter this life to the very moment that we say goodbye, there is one thing that connects us, and that is the fact that people have cared for us when we have not been able to care for ourselves, or we have learnt how to care for ourselves and other people that we love. So implicit, or whether we understand it or not, whether we can research it or not, that is a universal truth. But what we also know is that whether you're looking at aged care, social care, child care, health care, we know that there's huge variations in the way that care, our understanding of that care, is delivered. So we can see the variation, and we have to, as scientists, ask, well, why does that variation exist, and how could we move it to something that is more consistent and of a high quality? If you think about healthcare, we know that healthcare, so episodes of care that is bundled within an illness sort of metaphor, often episodic, clinically directed, crisis-related, rather than absolutely understanding where a person is from, where their family has come from, what are the issues, what can they do for themselves, and how do they need to know not to find themselves in that situation. Again, despite the rhetoric of integrated care, we know that across every health system in the world experiences one of fragmentation, gaps, blockages, and frustration. And then if you want to focus on essential or basic or fundamental care, we know from a lot of research that has been done on missed care or care that nurses choose to not do is because they see this as a lower importance to other things like medication or other sort of requirements. So this care, this fundamental care, is often perceived as common sense, and therefore is often not valued. So why are we still in this situation? Well, I think I had one of these light bulb moments recently where I suddenly discovered that what we were trying to sort, understand, come to terms with wasn't a straightforward traditional problem in the way that you try and analyze stuff, but this is a wicked problem. Delivering high quality fundamental care is, in contemporary language, a wicked problem. So why is it a wicked problem? Well, interestingly, if you think of our background understanding of where care, how we talk about care, how we value it in our society, there actually has been a lot of work over the centuries on how we understand the concept or the construct of care. So in order for us to understand why we still have this ongoing debate about why we can't deliver the sort of care or fundamental care that we want to deliver, we need to understand the antecedents. Now, from a philosophical perspective, you know that we will have moved from myths and legends that are common in most of our cultures, and here we have Cura, who's the goddess of hygiene and care in the Greek mythology, through to some of the Enlightenment philosophers, Kierkegaard, Goethe, who actually, after the Reformation, when religion wasn't such a strong sort of determinator of how human beings thought about things, you actually had this movement in the Renaissance where mostly men were thinking about how to live a good life. What does it mean to understand the world? So again, a lot of our philosophical thinking in Western philosophy was shaped and honed by this individual quest to understand what does being a human being mean, and how do you care for yourself? So this was one of the first times in philosophy that the idea of care was used. Interestingly, in the 19th and 20th century, the reflective individual notion sort of started to move through Heidegger and other phenomenologists into that notion that in order to understand oneself, you also had to be in relation. Meyerhoff in the 20th century, and most recently Erik Erikson, a social psychologist, started to talk about this notion of finding self through interaction with other people. Now, that huge sort of zoom through 2,000 years of historical understanding is just to really to reflect that there has been a sort of a pipeline of consciousness being created, which was picked up by nursing. Now, again, we all know that Florence Nightingale was the first leader of contemporary nursing in our Western society. Florence took care out of the home, put it into institutions through a huge movement around public health. She also chose to connect the public health sanitation movement with her own moral understanding of what it was like to serve other human beings. So hence the sort of the archetype, the sort of theoretical conceptual structure of nursing was set up. Again, significant influencers, Virginia Henderson, Dorothea Oram, whose self-care theory I think has a lot of resonance with the work we're doing, Carol Gilligan's work in feminist philosophy, very much, again, in the 70s, challenged the way that we were structuring our notions of care. And again, you couldn't talk about caring without acknowledging Jean Watson's work. Indeed, you have your own sort of champions, Carrie Martenson, Katie Eriksson, and Karen Dahlberg, all very strong Norwegian or Scandinavian nurses who have done a huge amount of work. So you might be thinking, so how does our understanding of care fit in to what, again, would be a dominant discourse, certainly in healthcare, the biomedical model, trying in the sort of periphery, a lot of talk about the biopsychosocial model, but we know that the biomedical paradigm is dominant, which creates difficulties for us, particularly if we are trying to move to a more integrated, holistic, relationship-centered approach. So this is why I'm sort of creating the argument of saying that researching care, and particularly fundamental care, is really a wicked problem, because it means that we're starting from universal, ubiquitous phenomenon that everybody has a view about, but we still haven't done the work to be able to isolate it, get consistency in the way that we use the language, which you know that if we don't have agreement in our language, it's very difficult to observe, to measure, to interpret, to understand what's actually happening. Equally, there's a lot of sort of time and effort required to not only generate theoretical and definitional scaffolding, but then to get the resources to actually sort of make it happen. So these are the reasons that I'm suggesting to you and possibly challenging you as the leaders of intellectual thought in nursing and in care across Scandinavia to sort of see what you can contribute to this wicked problem. So, for example, these are the range of terms that people might use to talk about this thing called fundamental care. Does it matter what we use? Are there differentiations? Is there an implicit theoretical diversity happening? We don't know, because we're sort of trying to sort of both understand the provenance, but also perhaps more pragmatically sort of come together and say, you know what, so long as we've got these broad areas, we can really start to move forward. And it does matter, because a recent study in Victoria, in Melbourne, showed that look at the number of items of information that nurses are collecting from their patients. So out of 11 hospital studies, just looking at admission criteria, there were, median of 11 forms that were filled out for each patient with over 300 items, with a huge variation in data items. Now, for those of you who like big data sets, you know that what's really important is that we're measuring the same thing. We know why we're asking questions and we're synthesizing it. So that, I think, just reflects that we have a bit more theoretical and conceptual work to do. So I've identified that the problem is one that we're still not getting care right. There are a range of reasons for that, suggesting it's a wicked problem and illustrating the fact that we still don't have theoretical, conceptual or definitional consistency in what we're doing. So what did we try and do to sort of change that situation? So I'm just going to give you a couple of illustrations of some of the work that myself and Tiff Conroy and members of the International Learning Collaborative did. Now, this was a really sort of simple, sort of off-the-shelf approach, where we sort of looked at the seminal nursing texts and then, in a very sort of basic way, looked at the amount of time that they talked about what we would call fundamentals of care. You can see that the ones that everybody agreed on were safety, nutrition, and elimination. And the ones that there was less agreement or explicit understanding about was comfort, pain management, privacy and dignity. That got us thinking about how would we construct what giving fundamental care would look like. And we sort of published the proceedings of our first co-design workshop that was held in Oxford. And I think the big breakthrough, and again, it's not like many of the theories that are presented are interactive and dynamic. We have argued that the fundamentals of care framework is not a list of things to do. It's relationship-based. It's integrating physical, psychosocial, relational within dynamic contexts. So if that was our starting point in the early 2010s, how have we refined and tested the framework? Well, again, having established the International Learning Collaborative, we undertook a sort of an inductive approach to develop the framework, co-designing it with an international team. We then undertook a number of further reviews particularly to test different parts of the framework. So our first area was undertaking systematic review of research that had been done on defining what the nurse-patient relationship was like. That was compared back to the inductive work and was published in Nursing Inquiry in 2016. We also, working with Dave Richards' team in Exeter and Claire Pentecost, they did a really nice bit of work looking at the level of evidence around discrete fundamentals of care, discovered that interventions were weakly designed, quality of the interventions could be improved. So again, lots of opportunities. We've undertaken scoping reviews, Delphi survey to refine the framework, and have looked at how fundamentals of care is taught. And currently, Tiff Conroy is looking at how nursing leaders enable fundamental of care delivery. So this is the updated framework that Beck Feo and an international team developed through Delphi survey. Again, we're sort of seeing this as a live and vibrant and iterative process. So this isn't the definitive framework. This framework will evolve and improve as we learn to work together. What is very exciting, though, is the work that we're doing around the middle bit of the framework. This was, again, generated inductively, tested deductively, and Beck Feo and a team have looked at evaluating the instruments that measure behavioural aspects of the nurse-patient relationship. So again, if you want to read that, go to Nursing Inquiry, because what it's found that even though there's like 24, 34 different measures, again, a lot of them do not stand up to scrutiny from a methodological point of view. Another early career researcher, Alex Mudd, has been, again, going back to the framework, checking out the most sort of commonly used theories in nursing at the minute. How does this work compare? And I just want to focus your attention on number 4 in particular, because even though I like theory, I'm an incredible pragmatist and practical. I like to see stuff happening on the ground. So if we have found that theories in the past have not been able to be used by practicing nurses, then I'll have to ask you, well, what's the point? What's the point in teaching them in education, using them for research, if they can't actually translate into practice? And this is where, again, if you want to see how we've been testing the practical application of the theory, a wonderful piece of work by Sylvie Ray, who herself is a PhD sort of student working in dementia care. She has used what we're trying to do and personalized it. And I just, again, would like to draw your attention about the top to increase self-care. So this is Emily speaking. Put me in front of the sink, no shower, no bath, no bed bath, no hair washing, hairdresser once every 2 weeks. Ask for my collaboration. with some verbal prompts and reminders, I can achieve the following self-care. So again, really particular. Now, I just think if we had that for every one of our patients or for our clients, wouldn't that just transform the way we deliver fundamental care? So again, and I was thinking as I was preparing this, I was thinking that a lot of you know, sort of debate that certainly historically has been the tension between the mind and the body, and you know, you almost have to punish the body in order to create the aesthetics or the sort of high level understanding of what life's about. And I'm just wondering whether some of our theories about care have sort of fallen into that trap, that they don't actually acknowledge the fact that we have to go to the toilet every day, and that act of going to the loo can either be something that is edifying, respectful and dignified, or something that leaves you traumatized. So how do we as nurses, as women, as carers, you know, actually come to that? So this is where the Caring Futures Institute and an interdisciplinary, transdisciplinary team of allied health medics, consumers, are actually trying to understand how the foundational direction of fundamental care actually can be put into a whole life course narrative. So what we have done is actually following a sort of a process of engaging with our research and practice leaders in the Caring Futures Institute, have produced this amalgam of taking a caring life course theory in order to suggest how we could embrace fundamental-based self-care and caring solutions. Again, if you want to have a look at this paper, it's published recently in Journal of Advanced Nursing. So this is what we're putting together now. The life course assumptions. What happens early on in your life affects later experiences. Intrinsic, i.e. things that happen inside you because of your genetics, biology. Extrinsic factors, that's the nurture stuff. That affects an individual's life course. We know that, but we're also saying that transition and trajectory, transition points, i.e. getting pregnant, becoming a mother, care trajectories, slipping a disc, having chronic back pain, those are the sorts of things that are going to affect our self-care needs, our ability to care for others, and our ability to care for ourselves. So how do you then connect that with the fundamental care need assumptions? So meeting another person's fundamental care needs is based on a trusting relationship. This is what we're arguing. So if you don't have a trusting relationship, or how do you make a judgment of what a trusting relationship looks like? And how do you know how to integrate the physical, the psychosocial, and the relational? And how do you make sure that context is operationalized? So this is really where it does look like a weather chart. Imagine born, okay? It's self-evident that you end up are totally dependent on other people to get you through the first few months of your life. As you grow and as you learn, your need on other people reduces because you're starting to know how to care for yourself. And implicitly, if you know how to care for yourself, you should be knowing how to care for other people. And then we sort of see that as you age, as you pick up chronic diseases, you might need more help. So that then means if we agree with the logic of that, you could say that, again, deductively, you could start to model different trajectories. So like here, you could say, this is a sort of a catastrophe. Somebody's had an accident. They need their ability to self-care is suddenly reduced, but they then start to come back and rehab. Then something else happens. And so you can sort of get the idea. Equally, you can say that you could make a judgment about a person's need for self-care, but where they aren't able to do it themselves. So you could actually begin to check as a nurse, as a professional, what the range of self-care and need for other people's is. So then the final idea would be, if you build all of that together, then you can see that if the sort of the sources, the care network that you live in is made up of people, informal carers, so that's your family, your friends, the people who will, help you out. Formal carers are the people who will go and do your groceries for you. And then the professionals. Now, I would be arguing that the professional carers like us are really the tip of the iceberg. And our challenge is to understand how we reach out and understand how the ecosystem of caring networks around the people we look after can be enhanced by us. Now that's in order for us to test those assumptions and that theory, we've just published a piece of work that's looking at theories of self-management and self-care. Again, a huge amount of debate in the literature around, are they the same, are they different, do they come from a different philosophical perspective? Michael Lawless and Matthew Tew, Rebecca Feo, myself, out of over 170 different articles, identified over 70 different theories that were being used to try and explain self-care, self-management, but we found that there were 7 very common elements, and those common elements, I'll not tell you what they are, go and read the paper, incredibly exciting. So next big challenges. Well, I have to pay tribute to my beautiful friend Eric Sorensen, who hosted our last International Learning Collaborative, where we realized this was a wicked problem. This is a wicked problem because you have to approach it on multiple fronts simultaneously, not getting overwhelmed by the size and the complexity and the profundity of it. But if we can do this together, value fundamental care, talk, do, own research, then we will be able to make a difference. And, I know everybody's so exhausted, so tired out with COVID. So much has been given by so many. And yet we're saying, oh, why don't you think about this? Well, look, I know it's a complex health system we're working on. So in order to solve our complex, wicked problems, we have to go from disconnections to interconnections, from linear thinking to circular thinking, from silos to total immersion, from solutions to revolution, to I can't read this writing, to analysis to synthesis, and to from I've got Tiff in the room with me as well, from simple units to multiple, integrated. So this is why I want you to think about joining up for the International Learning Collaborative, because you can see we've got all these people around the world who are activated, motivated, want to make a difference, want to solve a wicked problem, but we can't do it without not only you, but a whole transdisciplinary, the whole of the healthcare team and all of our consumers with us. If you're interested, here's an opportunity. We have Leadership for Fundamental Care, special edition. Think about putting something in. And if you are really challenged by this presentation, then we want to see you in Oxford, fingers crossed, 2022, second week in June, 2-day conference, Fundamental Care in Times of Crisis. How have we coped, not just with COVID, but with disaster, with climate change, with all of the things that us nurses are having to do. And then we will be piloting our International Learning Collaborative FOC, Fundamentals of Care Leadership program. So thank you all very much. Hopefully see you next year in Oxford. Bye.